Hi everyone, I'm Andy Liao. I'm a medical oncologist at the University of Chicago. Thank you for joining us. Today I'll be talking about medical oncology treatments for primary tumors and liver metastases. So when we think about medical oncology treatments, we're talking about systemic therapies. And some examples include somatostatin analogs, PRRT, targeted therapies, and traditional cytotoxic chemotherapy. And by definition, these treatments treat both primary tumors and liver metastases because they treat the entire body. However, we're going to look at how the liver tumor burden affects treatment efficacy. So we're going to start by talking about somatostatin analogs. So somatostatin analogs are widely used as first-line systemic therapy for patients with advanced neuroendocrine tumor. We have octreotide LAR, which was shown in the PROMIT study to significantly improve progression-free survival over placebo, with a response rate of only 2%. If you look at the patients by their liver tumor burden, it seems like those patients who have low liver tumor burden, defined as a tumor load of less than 10%, did much better compared to patients who had high liver tumor burden. So the median survival was 108 months for the low tumor burden patients compared to 58 months for the high tumor burden patients. Another somatostatin analog that we use is lanreotide, and this was shown in the CLARINET study to also significantly improve progression-free survival and leading to a response rate of 2%. If you look at the CLARINET trial subgroup analysis of the patients by their liver tumor burden, it seemed like both patients with low liver tumor burden and high liver tumor burden benefited from lanreotide. So shown here are the two different groups. So on the left are the patients who have low liver tumor burden. So in this patient population, lanreotide led to a hazard ratio of 0.34, meaning 66% reduction in the risk of progression or death. And shown on the right are the patients with high liver tumor burden, in which lanreotide led to a hazard ratio of 0.45, which means a 55% reduction in the risk of disease progression or death. So in other words, lanreotide benefited both groups of patients. So to summarize, both octreotide LAR and lanreotide improve progression-free survival compared to placebo. And we see this progression-free survival benefit in both low and high liver tumor burden patients. However, we also see that the high liver tumor burden patients have a worse prognosis, and so perhaps they will be moving on to other treatment options sooner in their treatment journey. And finally, to highlight, the response rates of these treatments are generally low in the single digits. And so if we are trying to get our patients to surgery, or if we need a significant tumor shrinkage to prevent impending liver failure, then perhaps we might be considering adding in additional therapies. So moving on to talk about targeted therapies. Here is a table that summarizes the FDA-approved targeted therapies for neuroendocrine tumors. So for pancreatic neuroendocrine tumors, we have everolimus and sunitinib. And for other neuroendocrine tumors of the GI tract and for the lung, we have everolimus. And all of these agents are proven in phase 3 clinical trials to have a significant improvement in progression-free survival compared to placebo. The response rate is only in the single digits, however, meaning that these treatments generally keep the tumor stable rather than shrink them. One of the newer targeted therapies that's currently under clinical trial investigation is cabozantinib. So this is the phase 3 CABINET study. So cabozantinib is a drug that targets the vascular endothelial growth factor pathway, affecting how tumors make new blood vessels, but also targets different pathways involved in the immune microenvironment of the tumor. So this is a phase 3 study that will randomize patients with advanced neuroendocrine tumors in a 2-to-1 fashion to getting cabozantinib versus placebo, and crossover is allowed for patients who are randomized to the placebo group, so it's currently accruing. Another newer targeted therapy agent is belzutifan, and this is approved for patients with pancreatic neuroendocrine tumors in the setting of von Hippel-Lindau disease. So this is the data from the phase 2 LIGHTSPARK-004 study, the pancreatic neuroendocrine tumor cohort, of which there were 22 patients. And in this study, treatment with belzutifan led to a response rate of 91%, with a median duration of response not reached by the time of the data report, and 7 out of 22 patients achieving a complete response. So this is only indicated for pancreatic neuroendocrine tumors that arise in a setting of von Hippel-Lindau disease. So now we'll move on to talk about traditional cytotoxic chemotherapy. So the best data we have for chemotherapy is with capecitabine and temozolomide, also known as CAPTEM. And this is based on a phase 2 clinical trial called the ECOG 2211 study that randomized patients with progressive pancreatic neuroendocrine tumors, grade 1 and 2, in a 1-to-1 fashion to getting capecitabine and temozolomide versus temozolomide. And as you know, capecitabine is given on day 1 to 14 out of every 28 days, with temozolomide being given from day 10 to 14 every 28 days. This study showed that capecitabine and temozolomide significantly improved progression-free survival compared to single-agent temozolomide. So the median PFS for CAPTEM was 23.2 months compared to 15.1 months in single-agent temozolomide. There was also a trend in improvement in overall survival. So the survival for CAPTEM was 58.7 months compared to 53.8 months for single-agent temozolomide. And unlike many of the other agents that we have talked about, CAPTEM can actually lead to significant tumor shrinkage. So the response rate of CAPTEM is 39.7%, with a median duration of response of 16.6 months. And this makes it an attractive agent in situations where we need rapid tumor reduction or when we need a lot of shrinkage to get patients to surgery or to get them out of impending liver failure and etc. So where are things moving with CAPTEM? So CAPTEM is being investigated in many different settings. So one is being used as adjuvant therapy, so meaning patients with localized pancreatic neuroendocrine tumors after surgery. Can we use CAPTEM to reduce the chance of recurrence and help people live longer? So this is the S2104 study. There's also a study comparing CAPTEM versus PRRT with lutetium dotatate to see which one is most efficacious. And so now we're talking about PRRT, peptide receptor radionuclide therapy. Peptide receptor radionuclide therapy are systemically administered radiopharmaceuticals. So essentially, these are drugs that target the somatostatin receptor, which are expressed in more than 80% of net tumor cells, and it's conjugated to a radionuclide such as lutetium or yttrium. So the FDA-approved version is lutetium dotatate, also known as Lutathera. The approval was based on the NETHER-1 study, which is a phase 3 study of lutetium dotatate in mid-gut neuroendocrine tumors. These patients are randomized to getting lutetium dotatate for 4 cycles with continuation of their octreotide LAR compared to the control group of a higher dose of octreotide LAR. And here are the results of the primary endpoint of the NETHER-1 study. So lutetium dotatate led to a significant improvement in progression-free survival at 28.4 months compared to 8.5 months in the control group. The hazard ratio was 0.21, meaning a 79% reduction in the risk of disease progression or death. So very, very significant. There was also a trend towards improvement in overall survival. So the median overall survival in the lutetium dotatate group was 48 months compared to 36.3 months in the control group, although this did not reach statistical significance. If you look at the objective tumor response, how many patients who have significant tumor shrinkage, the response rate for lutetium dotatate was 18% compared to 3% in the control group. And now we look at the effects of PRRT by the liver tumor burden of the patients. So shown here is subgroup analysis from the NETHER-1 study, looking at patients who have large liver tumors versus patients who don't. And they define large liver tumors as having more than one large lesion that's greater than 3 centimeters. So if you look at the survival curves in blue, so those are the survival curves of the PRRT group. In the top line, the blue solid line, are patients who do not have large liver lesions, and the blue dashed line are patients who do have large liver lesions. As you can see, patients who do not have large liver lesion definitely did much better in terms of progression-free survival compared to patients who do have large liver lesions. However, even the patients who do have large liver lesions benefited from PRRT compared to octreotide, which is a control arm. So the progression-free survival in that group was 28.4 months with PRRT compared to 8.4 months with octreotide. And now we'll look at some of the data for using PRRT in high-grade neuroendocrine tumors. So shown here is a summary of some of the smaller studies providing preliminary data. As you can see, PRRT can definitely lead to responses in higher grade neuroendocrine tumors. But if you look at the data here, it seems that the benefit is primarily in patients whose tumors have a Ki-67 of 21 to 55%. In patients whose tumors have a high Ki-67 of greater than 55%, it seems that the benefit is very limited, with a progression-free survival of only 4 to 6 months and overall survival of only 7 to 9 months. So PRRT is currently being further investigated as a treatment for higher grade neuroendocrine tumor in the COMPOSE study. Some other trials that are coming up for PRRT, there are many trials investigating combination strategies. So shown here just a few examples combining PRRT with DNA damage repair targeted agents. There's also trials looking at PRRT as preoperative therapy. So this is Dr. Koiken's trial of using PRRT in the preoperative setting before surgical cytoreduction. And you'll hear from other speakers in today's conference about alpha particle PRRT and intra-arterial PRRT that are coming in the future. And to conclude our talk, I just wanted to briefly highlight the role of immunotherapy in neuroendocrine tumors. We haven't been too successful with immunotherapy in neuroendocrine tumors. We know that generally speaking, single-agent checkpoint inhibitors have not led to any responses in low-grade neuroendocrine tumors. The best data we have for our current generation of immunotherapy comes from ipilimumab and nivolumab in this DART study that enrolled patients with progressive non-pancreatic neuroendocrine tumors and treated with combination immunotherapy with ipilimumab and nivolumab. And as you can see here, only the patients who had high-grade neuroendocrine tumors responded. So there were 18 patients in this group, and 44% of them had an objective response with a 6-month progression-free survival rate of 31% and the median survival of 11 months. And because of this preliminary data, ipilimumab and nivolumab has made it into the NCCN guidelines for the treatment of high-grade neuroendocrine tumors in the second-line and beyond setting. One of the most exciting immunotherapy treatments being developed is something called adaptive T-cell therapy. So this is a new immunotherapy approach for neuroendocrine tumors. What this is that they collect the patient's blood and isolate the T cells, which are the fighter cells of the immune system. They then engineer the T cells to recognize some specific marker on the surface of the tumor, such as the somatostatin receptor, and then they expand these engineered fighter cells and reinfuse them back to the patient. So this is a very promising new type of therapy that has already been shown to be effective in leukemias and lymphomas, and it's currently undergoing preclinical studies, and we hope to see clinical trials involving adaptive T-cell therapies for our NET patients soon. So that's the end of our talk. Thank you again for joining us.